Thank you, Naomi, Magdala, and Wendy, for sharing this important study and your valuable experience. It is impressive to see how there was a 25% reduction on neonatal mortality at 28 days in the intervention group. No wonder why these results have shaped the new WHO recommendations for caring for low birth weight babies. The results of this study indicate the need for a global paradigm shift in the care for low birth weight babies. To allow immediate KMC, we need to ensure that mother and her babies are kept together since birth. For those who want to read all the details on the study and the new WHO recommendations for low birth weight babies, please find them in the resource library. I would like now want to invite Dr. Barbara Moreno Sanz, pediatrician from La Paz University Hospital in Spain, who will share her experience on the implementation and scale up of family integrated care in the neonatal intensive care unit at her hospital. Over to you, Barbara.
Good morning, I'm Barbara Moreno Sanz. I'm a neonatologist from La Paz University Hospital in Madrid, Spain. And today I would like to share with all of you my experience with the family integrated care model, or as we commonly call FICARE, and the results we have obtained so far. We have published this paper in which we tell our experience from when we formed the working group until we started the pilot study. I will comment step by step how we did it. The burden of adverse short and long-term outcomes in the newborn who suffers prolonged neonatal intensive care unit stay is at least partially related to parental stress and family dysfunction. New healthcare models that focus on the family, the so-called family-centered care policies, have been proposed to overcome these issues. Family integrated care integrates parents in the direct care of their baby as part of the healthcare team and has been shown to have a positive impact on the infant's short-term clinical outcomes, parental empowerment, as well as decreases anxiety, depression, and post-traumatic stress on the families. Up to date, the reports of FICARE model implementation are almost limited to stable preterm infants admitted to NICU. We aim to adapt the 4 pillars of the FICARE model as described by professionals from Mount Sinai Hospital in Toronto to our level 3C neonatal intensive care unit. Our purpose was to scale up the parent training curricula, making it suitable to surgical and non-surgical, non-stable, high-risk infants. This presentation focuses on the FICARE implementation strategy used in our clinical setting and the effort used for its development. 2 potential limitations for the implementation of FICARE were considered: the absence of single family room and the COVID-19 pandemic. That was scheduled as Step 1, co-creation process to define the FICARE implementation protocol and to develop the training program and teaching material. Step 2, which consisted on the internal dissemination strategy among neonatal intensive care unit staff. And finally, Step 3, when we planned to start piloting the FICARE model at our setting to assess its feasibility and to refine procedures before it will be open to all admission once the architectural renovations is finished. Between March 2017 to April 2018, a co-creation process was undertaken by the FICARE implementation team that include nurse assistant, doctors, as well as psychologists and social workers from patient association, and veteran parents. An analysis of current procedures for critical care to identify needs, wishes, and requirements was carried out. As a result, the following entry and exclusion criteria to run the FICARE pilot inside were defined, basically covering all patient family dyads for whom more than 3 weeks of admission were expected and have no intellectual or language barriers to understand, providing a decision to provide full leave support was taken, and the family expressed their wish to be included and had signed the informed consent form. A critical point was to attend teaching session for what willingness to spend at least 6 hours per day in NICU was mandatory. A teaching manual was developed that covers both professional and parental curricula with several modules that were identified as the minimum training content to be delivered. Regarding family caregivers, taking part in baby care was categorized into intervention levels, basic and advanced, that cover specific task training for infants who require even more specialist care. A teacher education system was established. The FICARE coordinator defined the mentor-assigned training groups and the calendar. Face-to-face meeting to place along 2 months, reaching 90% of the NICU staff to become facilitators of FICARE. From July 2018 to December 2020, a total of 76 parents and 91 infants were included in the FICARE program. The most frequent neonatal diagnoses of participating infants were prematurity in 75% of cases, followed by congenital heart defects in 14%, and different genetic syndromes or congenital defects in less than 5% of the cases, including 2 infants with congenital diaphragmatic hernia assisted by extracorporeal oxygenation membrane. Median infant's age at enrollment was 1 week, without differences between preterm and other complex neonatal conditions. About the impact of COVID-19 pandemic, there were no differences in the number of infant dyads included in the program per month. In the pre-pandemic period, fathers and mothers spent a median of 7 and 10 hours respectively with their children, and in the post-pandemic period, 5 and 6 hours. Mothers spend more time in NICU than fathers, irrespective of the period that was observed. The family training process relied on workshops and individualized learning by task through face-to-face sessions at cut-size, following an individualized teaching plan adjusted to the baby's clinical condition and the wish of the parents. In 70% of the scheduled tasks, certification was accomplished within the expected time or earlier. 6 out of 20 blocks of tasks, however, took more time than expected for full accreditation. The feedback on the individual progress reported by either parents or professionals involved in training was used to adjust and refine the work plan. Barriers more frequently identified were nursing staff reluctant to fully adhere the model due to insecurity about parents our own knowledge, transfer of parental knowledge in changing nursing shift, and transition from neonatal intensive care unit to intermediate care halted parental training. Different actions such as grouping patients in the same ward, a standardized template to address the individual teaching plan, continuous education of neonatal intensive care unit staff, and weekly FICARE rounds by responsible person to ascertain individual progress were undertaken to foster FICARE implementation. The satisfaction questionnaire about the FICARE program for families revealed learning material, workshops, and code-side teaching sessions as essential for their training. Parents reveal decreased stress and anxiety and will accept to enter the FICARE program again through testimonies like, "My answer is yes, 1,000 times yes. This program was determined to learn how to deliver the care that my baby needs. The program allows us to behave as real parents and not mere observation of our baby's life." As conclusion, FICARE implementation in all levels of care in NICU is feasible even when facing two important adverse conditions. One, the absence of single family room facilities, and two, the strict visitor restrictive policies during the COVID-19 pandemic. Even in the case of thorough planning, continuous follow-up, and eventual adjustment according to the current condition to solve difficulties raised by both professionals and families are key elements for the project's success. And now what happened? The Rising Family is a project funded by European Commission through Horizon 2020 grant. The first objective is to scale up and adapt the FICARE model by including a wider geographical and sociocultural diversity at a total of 7 clinical sites at Zambia, Romania, Turkey, United Kingdom, Netherlands, and Spain. We all have to be able to implement this model in the hospital of the consortium, taking into account the sociocultural differences of each country. The project has been running for a year in which we have known each of the hospital and we have created all the necessary material to train healthcare professionals and the families. Now we will continue working hard in the next months to ensure that these countries can also benefit from the FICARE model. With this project, I want to show that this is possible in each hospital. It only takes people interested and involved in changing care for newborn and their families. Thank you for your attention.